So it's really my pleasure to introduce Dr. Terry Yao. Terry is professor of surgery at the University of Toronto and is the Angelo and Lorenza de Gasperis Chair in Cardiovascular Research. He's worked for 15 or so years trying to get to the point in time where they could inject stem cells into the heart of a patient with an infarction and heart failure to regenerate or reanimate the heart, and the timing is perfect because he did the first 3 patients in Ontario in the last 7 days, and this was widely reported in the print and TV media. And what was distinctly unusual about this, and in fact a Canadian first, is that the bone marrow was taken from the patient's iliac crest, processed in the operating room, and his own stem cells re-injected into him after Terry finished the bypass surgery. So this is truly new frontiers in cardiovascular therapy, and it's consistent with our vision to have a strong linkage between the McEwen Center for Regenerative Medicine and the Peter Munk Cardiac Center. Terry, look forward to your talk.
Barry, thank you for that kind introduction. I'm delighted to be up here to talk to you guys about the stem cell program at PMCC. I'm even more delighted to not be up here for the American Idol singing competition part that Peter was talking about there. So let me spend a few minutes just telling you about what the problem is and what we are trying to do now about this. So this is a depiction of a normal heart, which frankly I really don't see very much unless we are about to take this out of a organ donor and transplant it into somebody else. This is what we see more commonly. So a heart with progressive cardiomyopathy, often on the basis of one or more myocardial infarctions, sometimes on the basis of dilated cardiomyopathy or other causes. But a common pathway is ventricular dilatation, weakening, and progressive heart failure over time. And these patients, as you know, develop ongoing dyspnea, initially on exertion and then at rest, and ultimately wind up dying in heart failure. Now, about 50,000 Canadians are going to be diagnosed with heart failure every year. But sometimes, as I always think in those big statistics, people tend to get lost. So let me put it this way. Over the next 45 minutes while we're chatting and during that panel discussion, about another 5 Canadians are getting diagnosed with heart failure. And of those 2 are not going to survive to get to the PMCC Symposium next year. Now, rumor has it that besides not getting to the symposium next year, there are other disadvantages associated with dying, but not as important. So why is it that people die in heart failure after myocardial infarctions? We were all taught in medical school that basically the heart is a post-mitotic organ. Once you've grown the cardiomyocytes you have right now, those are all the ones you're ever going to have. And so when you lose them to myocardial infarction, they're gone and they're not going to come back. Now, we know now that that isn't exactly true. So in fact, there are a few ways that you can regenerate some of those cardiomyocytes. Okay, so there are some cardiac resident stem cells, and there are stem cells that are resident in your bone marrow. And in fact, there is an endogenous repair response that is active really in all of us, simply to a grossly inadequate degree. Otherwise, frankly, I'd have a lot more free time on my hands than I actually do. But one of the papers that actually demonstrated that this actually happened was this very interesting paper from Piero and Versa's group. And they looked at patients who had died many years after a heart transplant. And these were male transplant recipients in whom a female heart had been transplanted into them. Okay, now we do sort of gender mismatch transplants all the time. We don't really care about what gender the donor is, except insofar as it makes an impact on the size of the heart, and we're matching size of the donor heart to the size of the recipient. But this happens fairly commonly. So that when they did the autopsies and they looked at the supposedly female donor hearts, they in fact found that a high percentage of these hearts had male cells in them, which could only obviously have come from the recipient. And those cells, in fact, could be identified in that donor heart having formed what appeared to be normal-looking endothelial cells, smooth muscle cells, and cardiomyocytes. So in fact, those cells, which presumably come from the bone marrow, can regenerate the heart in any one of us to various extents, but simply not to a sufficient degree. So we know now that your own stem cells do contribute to the formation of new muscle, but when you look at them in a heart after injury, They're small, they're round, they don't look anything like normal cardiomyocytes, and it's kind of hard to imagine that they would function in the way that normal cardiomyocytes do, because that is quite dependent on morphology. So for most patients with end-stage heart disease, this operation is the gold standard. So this is a patient with a dilated cardiomyopathy undergoing heart transplantation. So right now you can see us cutting across the pulmonary artery, and you'll see the pulmonary valve here. Much to my chagrin, most of these operations are done at about 3 o'clock in the morning, which is when this one was done. I'm going to apologize in advance for a bit of the video being shaky, because my summer student was videoing this. I think this was the first time I'd been up at 3 o'clock in the morning, certainly in the cause of science, if not for other reasons. So we cut out the heart. And I'll show you a little bit more of the anatomy in a moment. But for patients with end-stage heart disease who are not amenable, or who have symptoms and longevity that is limited despite optimal medical therapy, this is in fact the gold standard. So here you see the old recipient heart, and it basically looks like a big floppy bag, and that's exactly as useful as it was to this last patient as a bag would be. So you can see the various valves that I'll show you in a moment, and you're going to see us sewing in the new donor heart, which looks a lot nicer. This is a tricuspid valve with its anterior and posterior and septal leaflets, and there's a mitral valve over here. This is a view that you don't get in most operations unless you're a lot more radical, even than we would be. And then you'll see the aortic and the pulmonary valves as well. And this is a great operation for people who have this kind of problem. Obviously, there are limitations to the therapy in general, in that patients have to be on immunosuppressive medications the rest of their life. We do have concerns about infection and cancer and those things, but basically you take a population of people who are essentially at death's door, and you give them superb long-term results. And so this is a very, very good operation. You can see here the donor heart is in my right hand there, and it looks a lot smaller and nicer than the old heart did. And for us to sew in this donor heart after the old heart comes out takes about an hour and a quarter. And then once all this is done, you'll see that the blood flow to the new heart has been restored. We're going to give it a little kick in the pants right here. And yeah, and it gets the idea that it's supposed to be doing some work here. So you can see here it's a lot snappier and a lot smaller than the old heart was. Okay? And so heart transplantation is a great therapy for people with this kind of problem. The biggest problem with heart transplantation is right here. So I told you that 50,000 Canadians are getting diagnosed with heart failure every year. In this entire country, about 200 of them are going to get a heart transplant. Okay? So what can we do for the rest of them? For a significant percentage of them, we'll be doing something like this. So the patient who comes after one or more myocardial infarctions and who obviously has coronary artery disease may very well be undergoing coronary bypass surgery. And this is us doing coronary bypass surgery, in this case on the right coronary artery. It tends to be the biggest coronary that you have, and so you can actually see this reasonably well without the loops that we normally wear to do this operation. And so that is good at relieving angina. It's good at reducing the likelihood of that patient having a heart attack in the future, and extending longevity compared to medical therapy alone. But clearly, it has some limitations. So if somebody comes for this after they've had a large myocardial infarction, that infarct area, even after bypass surgery, may continue to thin and dilate, and that patient may develop congestive heart failure despite having well-functioning grafts and having a low likelihood of having a heart attack again. So the idea then is to develop a therapy that might be an adjunct in this particular scenario, so that we can inject, hopefully, those cells into the infarct where they may engraft and limit ventricular dilatation and thinning and prevent that patient from developing heart failure. So how do we know that injecting cells into a heart can actually improve its function? In fact, the first study to demonstrate that you could do that actually came out of this institution a good 15 years ago now. And this was from Renke Lee's lab. And Renke had taken some scarred rat hearts and transplanted cardiomyocytes into those hearts, and shown several weeks later that those hearts beat better, and that you could follow those cells, which were still identifiable within the scar. But the early model was that of allotransplantation, and just like heart transplants in patients, if you don't take immunosuppressive medications, then you will lose all those cells over time to rejection. And so 6 months later, almost all of those cells had been lost. So what we do in the laboratory studies and what we do now in patients is auto-transplantation. So we're transplanting your own cells into you so that you don't really have any issues with rejection. So for many years, we did a lot of studies looking at transplantation of different muscle cell types because the thought was that, you've lost some heart muscle, we're going to give you some new heart muscle. About 10 years ago, one of our fellows who came from Japan and spent a couple of years in the lab was the first to demonstrate that you could take bone marrow cells, which clearly are nothing like muscle cells, and treat them in a way that would induce them to differentiate into something that looked kind of like heart muscle cells, transplant those into an injured heart, and actually improve function. And so that was the first demonstration that you could take what were pluripotent cells and achieve the same kind of effects as we had seen with muscle cell types. So this is a study that we did a few years ago looking at a direct comparison between the archetypal muscle cell replacement cell, which would be cardiomyocytes, and bone marrow cells. And what we did here was to harvest some cardiomyocytes and along with a small proportion of fibroblasts, smooth muscle cells, endothelial cells from the hearts of these pigs through a biopsy and grow them up over a period of several weeks to get a sufficient number of cells for us to be able to implant. And we did the same thing with bone marrow cells as well, and grew those up over a period of time, as you can see here. And then ultimately, once we had a sufficient number of cells, then implanted them into a myocardial infarction, in this case in pigs, which we had created by occluding that left anterior descending coronary artery angiographically. So we inject the cells into multiple locations, both in the center of the infarct and into the periphery, with the idea that we are not only putting them in the middle of the infarct, but also allowing the implanted cells to communicate with the surviving host cardiomyocytes. So this is how this was done in pigs, and when we follow them up by looking at myocardial perfusion, and this was a SPECT MIBI, you can see that the white areas in the pre-transplant graph on the left show normal perfusion, and the dark areas show reduced perfusion. In the post-cell implantation panel on the right, you'll see that there is a much reduced area of impaired perfusion. So you can see that cell implantation improves myocardial perfusion. The bar on the right hand actually quantitates what happens in the hearts that don't get any cells injected after myocardial infarction. And what you see is perfusion scores actually get worse with time as the scar thins out and dilates, and the scores get better in the groups that got bone marrow cells or cardiomyocytes, and they got better to a similar degree regardless of that cell type. So both cell types were equally effective at limiting adverse ventricular remodeling and dilatation, and they improved systolic function to the same degree. So we concluded from this that the cell transplantation approach was a promising one, and it didn't matter whether you put in muscle cells or bone marrow cells, that both improved systolic and diastolic function and limited adverse ventricular remodeling to a similar extent. Interestingly, the bone marrow cells clearly had greater plasticity because you'd put them into the heart and you'd get labeled cells, because we labeled all the bone marrow cells before we put them in to make it easier to track them afterwards. And you see these labeled what look like normal cardiomyocytes, smooth muscle cells, endothelial cells. So they actually differentiated into different cell types. So what we were trying to achieve then in patients was to take these stem cells out of the marrow and put them into the infarct. And we do this with a technique that is similar in many ways. So we harvest cells from the iliac crest, and this is our first patient here. So on the morning of his bypass surgery, he comes down to the recovery room. He gets a little bit of sedation. He gets some local anesthetic over his hip. And then we aspirate about 100 to 120 cc's of bone marrow out of the iliac crest in a way that is analogous to what is done for bone marrow biopsies, or when it's done in much larger volumes, about 1 liter or 2 liters may be aspirated when they're doing bone marrow transplants. Okay. And the hands that you see there are Armand Keatings. Armand is the president of the American Society of Hematology this year, so we obviously have a lot of high-priced help. So we're joking around saying that, if you aren't at least the president of the ASH, you're not qualified to do a bone marrow biopsy for us. So we take that 100 or 120 cc's of bone marrow and then walk it over about a 50-foot stretch to the Organ Regeneration Lab, which is the cell processing lab that is entirely within the operating room suites. And so this is the cell isolation setup that we use within that ORL. And we have to do a few things to this 120 cc's of bone marrow. We have to get all the sort of bony debris and fat that every one of us has in the bone marrow out. The red cells actually aren't any use to us, so we get rid of those things too. And ultimately what we're looking for is a tiny population of very specialized stem cells, okay, hematopoietic precursors that have cell surface markers for 3 different markers, including CD133. And that process takes us about 5 or 6 hours. And once that is complete, then we have to quantitate the product that we have and do all the quality assurance. So we are looking at the purity of the cells, how viable they are. We want to make sure that there's no endotoxin in this sample, and a host of other things that we have to look at. We also take specimens to assess sterility, but unlike every other test that we get back basically right away, the sterility tests obviously don't come back for a week, so that comes back after these cells have been implanted in the patients. We fax all of our information on each cell processing batch to Health Canada, and they get word back to us generally within the next hour or so. And once we've got final approval from them, then we can implant this into the patients. And this is how it's done. So the 120 cc's of bone marrow that we took out of this man in the morning comes back to me as about a 2 cc suspension of these stem cells. And the cells themselves constitute maybe about 1 in 500, 1 in 1,000 of the original white cells that came out of his marrow. And then this is injected in multiple sites into his infarct. This is that first patient. So this is a man who had had a very large anterior infarct. And you can see here where his infarct was. This is the left internal thoracic artery that has been grafted to the LAD, which runs down the front of the heart, but he still has this very large infarct. In fact, when he opened his chest, he had a lot of adhesions to the pericardium over here, which is what often happens when they have a big transmural infarct. And so we inject the cells in this man's about 7 different locations into the center of the infarct and into the periphery as well. And that was all done after the completion of the coronary bypass procedure, but while the patient is still in the bypass machine and while the heart is still immobilized. So this is all being done as part of this clinical trial. And there are a variety of inclusion criteria for patients to be in this trial, but the most important ones are those here. So we're looking for patients with ischemic cardiomyopathy with left ventricular ejection fraction somewhere between 25 and 45%. Generally, they will have pretty obvious regional wall motion abnormalities because of their previous infarcts. And importantly, these patients need to have an indication for coronary bypass surgery. So in this particular trial, this is really being done as an adjunct to coronary bypass surgery. Now, there are a variety of other inclusion and exclusion criteria, the usual things related to clinical trials. You can't have terrible liver or kidney disease. You have to be able to comply with a follow-up and a variety of other things, but these are the most important ones. Okay. So we're going to be following these patients up for 1.5 years at a minimum, but we're going to be assessing them for our primary outcomes at 6 months. And the first 2 patients we know got cells because they were open label. The next 18 of the 20 patients that we're going to put into this trial are all randomized, and in fact, I'm getting blinded. So I get a suspension of something in the operating room at the end of the day, and I inject into the patient, but I don't know what I'm putting in there, and the patient doesn't know either. 6 months after the last patient is done, then we unblind all this, and then we'll be able to see what effect the cells had over and above that of bypass surgery. Okay. So the first thing that we want to do is to make sure that this is a perfectly safe process for our patients. So safety is the primary outcome in this particular trial. We're also looking at measures of feasibility. How reproducibly can we take the marrow out of these patients, get the stem cell population that we want, and re-inject it back into them? We're going to looking at efficacy as well. So we'll be looking with a variety of very sensitive tests, including perfusion MRIs and things like that, at whether or not these cells can actually improve the function and perfusion of the infarct area. So this is patient number 1, and a few of you may have seen his face on the National a couple of nights ago or on Global last night. But he's a 67-year-old man who works in an auto body shop, i.e. he's a pretty tough guy and used to working pretty hard. So he had a few days' worth of what he thought was indigestion. He really wasn't feeling very good. He was kind of short of breath doing his usual stuff. But he had put it aside for the time being, as many of our patients do. And after 5 days, eventually he said, yeah, this isn't right. He went to see his family physician, had an electrocardiogram which demonstrated an anterior myocardial infarction, went to the hospital, got admitted, and had coronary angiography which demonstrated extensive triple vessel disease. He also has grade 3 left ventricular dysfunction with an ejection fraction in the high 20s and a very large anterior wall motion abnormality correlating with his infarct. So in fact, we had approached him about this trial back in November when he had his infarct. And at that point, we were all ready to operate on him, but a study-mandated MRI, which he wouldn't have had otherwise, demonstrated, in fact, that he had a couple of left ventricular thrombi. Now, those are a concern to us because if we operate on somebody and we're manipulating the heart during the operation, those thrombi may break off and cause an intraoperative stroke. So he was lucky in a couple ways in that because he was in the study, he got this MRI, and that showed us that he had this problem. So we delayed his operation, sent him away for a few weeks, anticoagulated him, brought him back, confirmed that he had no more thrombus, and then operated him last week. So he had his triple bypass and stem cell implant, quadruple bypass and stem cell implant last Thursday, did phenomenally well, was out of the ICU in a couple of days, and is literally, I expect, going home this weekend. So he was patient number 1. And our second patient we did on Tuesday. So this was a man who presented with a slightly similar story, but a non-STEMI, complicated by congestive heart failure. Again, triple vessel disease. His presenting non-STEMI wasn't actually as big as the other man's, but in fact it looked like he had had multiple infarcts in the past and had quite diffuse hypokinesis. So he underwent his triple bypass and stem cell implant on Tuesday. Again, has done well. He's on the ward now, and hopefully around the middle of this week coming up, will be home again. So those are the first 2 of the 20 patients that we anticipate enrolling in this trial. But obviously there are many steps forward to this. Like, this is, I hesitate to say step 1 because we've been working on this for so long already. But whatever step it is, we've got a lot more steps planned, and there will be a lot more steps before we're doing this in tens of thousands of patients a year. So that part is clear. So we are not anywhere near the end of the road, but I think this is a very promising middle of the road there. And so we'll be proceeding along with various protocols, including not just the unmodified stem cells that we're using now, but we've also done a lot of work in the past looking at genetic modification of the cells in ways that will allow them to work better once we implant them and to survive better, simply because we're always obviously implanting these cells into an environment that is hostile. We put them there because your own cardiomyocytes died. So there's obviously a stress on the new cells that we put in there as well. And we can engineer these cells to express various therapeutically useful transgenes that will help them survive and help them improve your heart better. And we've also done some work that demonstrates that if you pre-treat the myocardial infarction with a laser in a process that we call transmyocardial revascularization, you can then improve the survival and the function of the subsequently implanted stem cells. So those are some of the ways in which the stem cell program will be proceeding with time. But obviously this represents a huge amount of work that was done by a host of people without whom none of this would have been possible. And there's a lot of names of the people who have made this possible, as you can see here. And in fact, most of them are actually speakers during this conference. So you'll see them and be able to ask some questions about all those various things as well. But that's the very, very current state of our program up to the minute. I think we're quite excited about this. It's really a new direction that we're bringing to patients now. So I'll be happy to answer your questions along with the other panel members. And in the meantime, thanks for your time.
So if I could ask the previous 3 speakers to join us on the panel, please. So I anticipate that there may be some questions about which form of revascularization to undertake, PCI, plus or minus stenting, or coronary revascularization, open or medical management. And just as we're getting this together, I'd like to highlight that we're going to be trialing something new at the PMCC. When patients go to the cath lab and they're found to have significant three-vessel disease, our protocol, which we're going to assess, is going to be to have the cardiologist call a cardiac surgeon and have the two together decide, with the catheter still in the patient's groin, what's the best treatment. So this is an evolution of the working in multidisciplinary teams to approach to try and give the best treatment for every patient. And you can imagine, with the strong feelings that have been expressed about which is better, that's going to make for some interesting interactions. So, first question we had actually related to PMIBI. When do you do a nuclear test as opposed to doing a stressed walking test? Where does this fit into your diagnostic algorithm? Maybe Peter or Lynn could take that one.
Well, if you can get a lot of value out of a stress test that you can't out of a percent MIBI, because you can see how the patient responds to exercise. The percent, I think, is very applicable when there are some problems, equivocating factors in doing with the ECG and doing the stress test. So patients who have left bundle branch block, right bundle branch block, other conduction issues, or on digoxin can give misleading or non-interpretable ECG changes, and that doesn't apply to percent, which doesn't really use the ECG. It's the images that count. Or if a patient can't exercise for one reason or another, or can't reach their target heart rate, then I think a percent MIBI is valuable and gives you extra imaging information.
I think that's very sensible advice, and I think the emphasis you put on the stress test, the stress ECG, you get a lot of information. You get the duration in particular and how the patient does on the treadmill. And if they have a superb duration, they are low risk, essentially whatever their underlying anatomy is. And you're not going to do or should not proceed with a nuclear scan after that. But in all the circumstances you've said, the nuclear will give you additional information.
Okay, so we need to ratchet this up a little bit. Peter, we heard compelling evidence from Viv why surgery is better in terms of survival and in terms of freedom from reintervention. So why is anybody getting a PCI?
Well, because we should readdress the whole, well, I mean, we should go through every slide that Viv put up, but, you know, the patients, he put up survival, freedom from repeat revascularization, avoiding surgery. The patient who we see and everyone sees before they see Viv, their first priority is avoiding surgery. It's not the third.